Hello, everyone, and welcome to today's keynote webinar titled The Future of COVID-19, Expectations and Lessons. This webinar is part of the 8th Coronavirus Virtual Event Series, and I am Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots. So let's get started. Before we begin, I want to remind everyone that this event is interactive. We encourage you to first participate by communicating with other attendees using our new live chat feature during the presentation. You can find that live chat located at the left of your screen. You can also participate by submitting as many questions as you want during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Now, if you have any trouble hearing or seeing this presentation, just click on the Help Desk button located at the top of your screen within the navigation bar or from the lobby. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the continuing education credits link located at the abstract window below the presentation window and follow the process to obtain those credits. I now present today's speaker, Dr. Ali Mokdad, Chief Strategy Officer at the Population Health in the University of Washington, and the Director of Middle Eastern Initiatives and the Professor of Health Metrics Sciences at the Institute for Health Metric and Evaluation. For a complete biography of our speakers, please visit the Presenter tab from the menu at the left of your screen. Dr. Mokdad, welcome again. You may now begin your presentation, sir.
Thank you, and good morning from Seattle to everybody. It's a pleasure to be here and to share with you some of the lessons and expectations that from COVID-19. My presentation today will cover briefly the Institute for Health Metric and Evaluation where I work. It's very important to give you that background information about IHME because that's what enabled us to be able to do the COVID-19 projections, and it gives you some insights on the data that we use for our projections as well. I'm going to talk about the current situation of COVID-19, about the forecast, and what countries can do, and what we have learned so far when it comes to the pandemic. So the IHME was founded in 2007 as part of the University of Washington here. We are about 550 full-time professionals here. And we have about 7,700 collaborators all over the world that work with us on many of the products that we produce here at IHME. And I will briefly tell you some of the products that we provide here at IHME. The first one is the global burden of disease. Many of you may have seen a lot of publications from the global burden of disease, where it's a systematic scientific project to measure deaths, disability, and what's the burden of health for each of the countries. And then we have so many new measures that we introduced. One of them is years of life lost. So basically, we take the highest life expectancy in the world, a Japanese woman at 86, somebody dying in Seattle at age 60, that's 26 years of life lost. And we can attribute those to a cause or a risk factor or an injury. And we do the same for disability. So basically, somebody in Seattle at age 60 getting diabetes, depending on how severe the condition is, we assign disability to it, and we say how many years have been lived on disability. And putting the two together, disability and years of life lost, will tell you what's killing and what's ailing the population, which is a very good indicator of the health. We do this from 1990 to now in all countries in the world, and of course in many places at the subnational level. Once you have this burden of disease, the second project we do here at IHME is we take that and forecast it to 2040. And that we're not interested only in telling where diabetes will be in 2040 in a location, in a state, for example, in the US. We're more interested in what if scenarios. If obesity goes down by 5%, what will happen to diabetes? We also do what we call local burden of disease, where we provide burden of disease at the local level, 5 by 5 kilometers, using small area estimates methodology. We monitor all the sustainable development goals that the UN has put forward, the 41 health-related ones. And for each country, we tell you where you are, which one you're going to meet, which one you're not going to meet. All what we do it also by social demographic index, which is an index based on education, fertility under the age of 25, and of course, GDP, the income of a country, lag. And this indicator is a very strong predictor of health. So basically, depending on where you are as a country on this spectrum of social development index, we can see if you are performing above or below expectation, comparing you to other countries and how they perform. We do something here called the Human Capital Index, which is for ages 20 to 64. It's an indicator based on education and health, how healthy the population 20 to 64, the probability of dying between ages 20 and 64. And education, we have two measurements for education: years of schooling and also learning, which is based on international and national tests. And why we care about Human Capital Index, it's a strong predictor of economical development. And we produce those for every country in the world and the progress that's been made. We provide something called healthcare and access quality index for each of the countries and the location. This based on 32 conditions where we know if there is a good medical system and there is a good access to it. Appendix, nobody should die from an appendix. And we rank all countries based on healthcare access and quality of care. We do monitor the money, who's spending money on what, how much out of pocket, what diseases are costing more, and we do forecasting of spending. And for countries like the US, where we have good information on health spending, we can do the composition. The increase in spending in the US, is it due to aging, growth of the population, pricing of medication, and also, of course, by inpatient, outpatient, and by risk factors. So these products have enabled us at IHME, because we have all this data on a regular basis, that has allowed us to immediately, within the COVID-19, early on when it started, to move into doing these projections, because we were doing this forecasting anyway. And many of the data that we use in our projections for COVID-19, we already have collected this data and we use it in our business, daily business. And that has given us an advantage. So our models, our projections, many people have done a very good job in projections, so we're not the only one. But our model has been consistently one of the best performing models and projections throughout this pandemic. And to give you a brief history about our model, we started doing this in March 2020 at the request of our own hospitals here at the University of Washington, because as you all remember, the first case was here, the first diagnosed case was here in Seattle. And the first deaths here, again, known deaths from COVID-19 happened here in Seattle. So our hospitals wanted to be prepared, and we started doing this. And early on, because we didn't have most of the data, mandates, mobility, a lot of things that we didn't have at that time, and we didn't have a good incidence or prevalence of COVID-19 because testing wasn't as good at the time. So we used mortality and we walked backward in order to get the infection. So basically take mortality, how many have been hospitalized, look at the hospitals out of those people, and backward. Then in May 2020, when the data became much better and more available in terms of testing, we switched to what we usually do in infectious disease SEIR model. And then we started including vaccination, we started including the variants type, we had mobility, mask wearing, we started including mandates for every country at that time and every location, and we started including new variants and spread of new variants. So we look somewhere else how it's spreading, we monitor that spread, we got data from travel, from airlines, and we were able to put all of this together, knowing if a variant has been introduced in a location, how long it will take to spread and how it will spread, competing with the other variants from previous experience, and we were able to include all of those in our model. And briefly, our models are based on looking at the past and getting the past right. And that's very important for projection. So you need to triangulate the past infections using all available data. And what you're looking at here on the top left corner in green is the infections and reported cases. We'll look at it. And then hospitalization in blue, the second one, how many people are being admitted to a hospital for COVID-19, and mortality, which is in red. And you could see here the spikes and how it has impacted hospitalization and mortality. Having reported cases, and we have all the surveys, we can tell what's the infection detection rate. So how many reported cases from the blood surveys, how many infections. Many countries do these surveys routinely and they post them. So you could estimate infection detection rate. Out the cases that are out there, how many have been detected. Once you have that, how many infections, you are able to look at infection hospitalization rate. Out of people who have been infected, how many have been hospitalized? And you could do infection mortality rate out of people who have been infected, not cases reported. Of the total people who have been infected, how many people have died? And that's very important for us to understand how the virus is behaving and how it's moving forward. So let's look at the current situation right now. If you look at mobility in everywhere globally, and even in the United States, you could see that people went back to the mobility similar to what we used to see in 2020. Basically, the whole world has gone back to pre-pandemic behaviors when it comes to mobility, people getting out. And we track those mobility data because we are able to use cell phone, Facebook that provide this data, and we can see people moving from the location where they usually are. The second one to keep in mind is mask wearing. Barely anybody wears a mask. I traveled to London for a function and I went to Lebanon to see my mom. Nobody is wearing a mask even on planes. And, one or few people, one of them myself, wearing a mask. So mask wearing is very low. So we need to keep that in mind, that people are moving more and then less wearing masks. When it comes to vaccination, vaccinations are still very low. And you see a huge variation here in the United States. And I'm looking here at percent of fully vaccinated. These are 2 doses, not the 3, not the 4, not getting the new booster right now. So it's very important to remember that vaccination is still very low. Even here in the United States, about 66% when it comes to 2 doses. And the uptake of the new modified COVID-19 booster has been very slow. And to put it together all, this is based on surveys that Facebook is doing and then provided to everybody to analyze. When you look at the proportion of people who want a vaccine and have not been able to get it, there is a lot of discussions right now that many poor countries cannot get the vaccine, and we need to share the vaccine with them, which is totally true. We need to share and we need to help. We're not safe until everybody is safe. But when you look at the data itself, maybe about 5% globally of people who want a vaccine haven't been able to get a vaccine. So we reach a point that people who are getting the vaccine are maxed, and there is not much more uptake of the vaccine moving forward globally. And then we see it here in the United States. So as a result, when you look at the percent of people who've been infected, which we do have, and the percent of people who've been vaccinated, taking into account the waning period of the vaccines and the infections, you could see that about 65% of the population here in the United States, globally, is protected from Omicron or any subvariant similar to Omicron. More people, of course, are protected for Delta because Delta has came before, and then now they're getting Omicron. It's providing some protection against the Delta. So if you look at it, flip it and look at it, about 35% of the population right now globally of the globe is susceptible for COVID-19. And then I'm not talking about a new variant that's an immune escape variant that the vaccines and the previous infection do not provide protection for it. So assuming that nothing new comes up that's immune escape, This is where we are right now. And this immunity will go down since vaccination is not going up. And the only way we're getting protection is through infection, but that will wane as well with time. So the current situation as of August 29, we're updating our models this week. So please keep an eye on IHME webpage. You will see the new update and the new projection coming out sometimes on Friday. So we're working on them right now. I couldn't finish them in order to present them today. So based on August 29, about 77% of people globally in the world have been infected, at least once. And of course, doesn't mean that 77%, as I showed you, are protected because of waning immunity. The infection detection rate globally is 2%. Out of the cases out there that are being infected, we are only detecting 2%. In the United States, it's 4%. So again, many people are testing themselves at home. Many of the subvariants of Omicron are infecting people and they have asymptomatic. People don't know they're being infected and they're out and about. Mortality is about 2,200 per day on average, and deaths, and then total deaths. Remember, some of the cases that we report are COVID. There is total COVID mortality. People are dying from delayed care. People are dying from other conditions that COVID has caused it. If you take COVID out, this would not have happened. Then the mortality is more than double. It's about 4,700 per day. When you look at surveillance right now, what we are doing, every country, because of the wider use of rapid tests at home, many people are not reporting. I mean, they're very valuable, they're helpful. People are going to a wedding, they test themselves. People are going to a big function. So it helps finding who's positive and they stay at home. This is very good, and they've been really doing a good job. But the implication of it, many people are not reporting these cases to the local health authority. They're not being reported to CDC, and then we don't know about them. So when you look at the reported cases right now, I told you it's 2% and 4% in the US. It's really meaningful. It doesn't have any, meaningless. It doesn't have, it doesn't help us anymore. So in the UK, the Office of National Statistics, they do an infection survey, and they've been doing it on a regular basis. When you look at it, the infections are way more higher than what's been reported in the UK, and it mirrors what they see in terms of admissions. So when admissions go up, the infection from the survey go up. So the best indicator right now is not reported cases, it's really admissions for COVID-19, and of course, how many people are in an ICU. However, many countries do not report to WHO admission. So we don't have that data for many countries. When we do our projections, we don't have admissions. We have to use other places and in order to impute it for the countries. So we need, as far as surveillance, and here is one of the lessons we have learned, is we need to get better data on hospital admission, and we need to split the hospital admissions for people who are coming with COVID. Somebody's coming to do another procedure, and they test them and they turn out to be positive for COVID, but they don't have any symptoms, or people who are coming for COVID-19. And we need to be able to distinguish these two because it will help all of us in the projection. So that's the situation that we are in right now. So what's the forecasting? And before I talk about the forecasting, let's look at what the determinants of this forecasting and how much information of these determinants we have. So the fraction of population that's susceptible in every location, remember I told you about 35%, 40% are susceptible to Omicron. It varies by location, and that's the main driver of what will happen next. It's how many people you have susceptible. And that, of course, depend on the infection-acquired immunity, since less vaccines are being delivered right now, more infections are happening. It's how long that infection will provide you immunity and how fast it will wane, and how much that infection of Omicron BA.5 provide you immunity for the next variant that's coming in. And remember, some of these new variants that are popping up right now, 2-3 weeks or 1 month ago, and I'll give you some examples. It's very hard for us to know the immunity against this new variant, BXX in Singapore, which I will show you, how much immunity you are getting from BA.5 or BA.4 infection against those ones. So it's still to tell, we look at indications, and I'll give you an example to know what's happening with these new variants. So again, the protection from a vaccine and from infection, we know very well wanes faster than we ever expected. 3 to 4 months, it goes down. 5 to 6 months is about 20%. But the protection against severe disease and hospitalization is very high. And that's very important to remember, that the vaccines protect you against severe hospitalization and mortality. And that's very important to do. Now, if we have a new variant that is an immune escape variant, that the vaccines are not as effective and previous infection is not as protective, then the forecasting will change totally different. So this is the situation we are in right now. One of the also future scenarios we need to keep in mind, China. China has done a very good job through zero COVID. You could debate if it was a good policy, how much is damaging the economy, is it good for the country? And I wrote a piece about that, but has done a good job of containing the spread of the virus in China. As a result, China has lower protection. The vaccine is not as good as the mRNA vaccines that we have, and they have few infections. So more people, more than 40% in China, are susceptible to Omicron. And if that happens in China, if China changes the policy of zero COVID, all our projections globally will be impacted by the large infections in China. We don't believe, and if you listen to the president during the meeting, he was very keen on saying, I will continue the zero COVID policy. So we don't, in our forecasting, we don't put in the models right now that China will open up, that infections will increase during to China opening up. Our future scenarios, of course, do not include an emergence of a new variant, which I told you. Such variant will make a huge difference. But before we go into the projections, let's look at what's happening right now globally. And this is showing you Singapore, Germany, and France. You see a huge increase in cases, reported cases. And I told you, reported cases are not as informative as hospitalization right now. So if you look at Germany, for example, yes, a sharp increase in reported cases in France and Singapore. But in Germany, for example, when you look at our data right now that we are monitoring, the middle line here, which is hospitalization. So reported cases and hospitalization. Hospitalization is almost as high as the peak of admissions in Germany. So that's scary. What you're seeing right now in Germany, cases are going up, but hospitalization are going even higher. And that proportion of people who've been hospitalized is very high. Not so much mortality. And remember, the hospitalization here include people with and people who came for COVID-19. So in Singapore, hospitalization did not increase, although Singapore has a very large increase in cases, BXX. However, it's less severe, it's not sending people to the hospital, and the admission is lower than what we have seen during the peak of Omicron. So you have two patterns here. One in Singapore, where cases are increasing rapidly, hospitalization did not. Whereas in Germany, BA5 is going up fast, but hospitalization is increasing. And you could look at what's happening here. Singapore is a good country in terms of vaccination, Germany too. But Germany, there's been a lot of events in October, a lot of festivals in October. So could explain some of it, but it's a pattern to keep in mind that if this happens in the United States, its implication, or if we have the model that we are seeing in Singapore. The other thing that everybody is keeping an eye on is the emergence of new variant. This virus, a protein virus, has a lot of room still to mutate. And we're seeing a lot of new variants here in the United States. What I'm showing you here is by CDC in the United States, but we're seeing a lot of variants all over the world that are spreading so fast. And some of them, like what I showed you, BXX in Singapore, are causing more infections, but they're not leading to a lot of hospitalization. The one in Germany, of course, are leading to more hospitalization. It says push to audience. I don't know if I can move the screen.
It's okay, just push the push the audience button. Perfect.
Right. And then before we go into the projection, thanks. Let's look at flu. And everybody now in the United States is saying, oh, we're going to have a bad flu season, and we're going to overwhelm our hospitals because we'll have a dual, increase in cases from COVID-19 and also from the flu. So let's look at flu in Australia. The first one on the left is cases. And you could see the red is this season right now. It came earlier than previous seasons. It peaked at a much higher rate. But if you look at under the curve, less cases than what we have seen in 2019, 2020, 2021. But it came earlier and more cases in a shorter period of time. If you look at hospitalization, the next one in Australia, it was high, again, came earlier, peaked, but it was much lower than the two previous years, more than 2018, but previous than the 2 years during the pandemic. When you put that and compare, same in the UK, the data that we are monitoring for flu, we are not seeing a spike in flu yet in the UK, neither hospitalization from flu compared to the previous years, 2020, 2021. Now, comparing to the US, Australia to the US, in the United States, excuse me, in the United States, we had more flu in 2020, 2020, less flu than previously in the US because all of us were wearing a mask and we stayed at home, but we had more flu cases than in Australia. So that could help us in a way that we have seen some flu and more than Australia. So if this model and the flu that's hitting us here in the United States will be the same variant, no mutation for the flu, and if our vaccine is very good and effective against the flu, yes, we should see increased cases of COVID-19 flu in the United States, but hopefully it's not as bad as everybody is worried about. So what's the projections right now? So a surge is expected in the United States. No doubt we'll have a surge, increase in cases, increase in hospitalization, and increase in mortality, but not as high as what we have seen before. So the infection fatality rate will be much lower because these variants that are circulating are less severe. The hospitalization will be lower because the previous infection and vaccines are protecting from hospitalization, but cases will increase in the United States. Again, this is short of a new variant circulating in the United States. And in the Northern Hemisphere, we're seeing UK start to go up. We're monitoring the data in the Northeast here in the United States is going up. The one that we are keeping an eye on is New York and New York City because of the airport, and it's really a bellwether of what will happen in the United States. We're seeing a slight rise in cases. And of course, the pressure of the hospital because of flu, even if it is lower than what we had before, similar to Australia, still coming all together in a shorter time, it's going to overwhelm our hospitals. And our hospitals are already stressed, and 3 years of COVID-19 has really damaged our hospitals. So our forecasting right now, again, look at our forecasting on Friday. We're expecting a surge in the Northern Hemisphere. Infection fatality rate and infection hospitalization rate will be much lower than we have seen before, of course, if we don't have a new variant that's circulating here. So what can countries do? And it's very important to focus on what can we do here. Maintain surveillance in order to be able to detect early on if there is a surge in a location. I'd like to know, I live in Seattle, I'd like to know if cases are going up in Seattle, and it's as soon as you tell me, I'll take more precautions, and then we can avoid the spread of this virus during the season. So it's very important for us to maintain surveillance. It's not the time to relax surveillance right now, especially as we are coming into winter, into the Northern Hemisphere, where we know cases are going to increase. So it's the best time to do the surveillance, do the genetic sequencing of the virus to know what's circulating. Is it a new variant? And as soon as possible, and remember, there is a delay, but as soon as possible to find out if it's an immune escape or not. Is it sending people to the hospitals, like what we are seeing in Germany, or it's a new variant that we know of, but it's not sending people to the hospitals, like in Singapore, which is very important for us to know. Ensure that you have enough antivirals for everybody. Again, that requires early detection, making sure that you have access to it and you get it as soon as possible. And of course, ensure that the boosters are available and encourage people to go and get the boosters. So some of the language, people coming out and saying, the pandemic is over, including our president who said the pandemic is over, it doesn't help us with pushing a message right now that please go get your booster and get your flu shot. If you're telling people it's over, it's not helping people to get the vaccine. That's one. Two, I think CDC, quite honestly, and NIH made a mistake by selling this vaccine as it protects you from infection. It doesn't. Vaccines are good. This kind of vaccine is very good in protecting you from getting to the hospital or going to the morgue. And then we need to stress that message and tell people, go get the vaccine. Even if you have, got COVID-19 a while back, you're susceptible again, you need to go and get the vaccine because you protect yourself. And we're coming into holidays, and the best thing you can do for yourself as a gift, whatever you celebrate this holiday season, the best gift you could give to yourself and to people you care about and you love is protection. You protect them. You don't bring to the dining table or dinner table a virus, whether it is flu or COVID-19. Go get the vaccine. Given the current state of the pandemic, and here may be controversial, but it's very important for me to stress that, given the absence of a new variant, I quite honestly, and here at IHME, we don't feel that the government should be forcing mandates again or suggesting mandates. We don't see it. We don't see the need for it right now. However, this changes if cases are start to go up in a location, and it has to be location by location. But having mandates like what we used to have before, I don't think that helpful or are needed given the current situation. Given the current situation right now, if this change, we need to definitely go back and do something else. So one of the recommendations is for countries to monitor the situation, assess if they need these mandates. But quite honestly, right now, what we see, what kind of variants circulating, these mandates are not needed. And look around you, people are not wearing a mask, mortality is not going up. But it's very easy for me to say that if I am a young, unhealthy person, somebody like me, my mom is very old, has medical condition, I need to be more careful because I need to protect my mom. Again, you assess your own situation and behave accordingly. But at the general public, these mandates are not needed with the current situation. This may change in winter as cases go up. Mask mandates may come back, physical distance mandate may come back, but we need to look at it at the same time based on the situation. So what we have learned, and I want to stop here and open it for questions, what we have learned during this pandemic. And I hope these lessons will be with us for a long time, and attention will still, people moved on. Nobody's talking about COVID for a good reason, there is a war in Ukraine, there is inflation right now, economy is bad, many people are concerned about, especially in Europe, heating their homes. So people moved on for one reason or another. But still, what we have learned is we need good surveillance. Surveillance was lacking in many parts of the world, even here in the United States. And quite honestly, throughout this pandemic, we got data on vaccine effectiveness, on genetic sequencing of the virus from Israel, did a very good job keeping up with the virus, Qatar, sometimes from Germany, but the most helpful for us was the UK. They have universal health care, they monitor everybody, they know who got the vaccine, who got sick, and it was very valuable data that has really helped us here to understand what's happening in COVID-19. What we have learned also is the power and the need for a good communication. We scientists, I could make a presentation like this and talk to you about the models and what we do and the statistics behind it. But we really need to make sure that we can communicate to the public in the right language and make a message that they understand. And also, what we have learned during this pandemic is it's okay in a public health or institution like CDC to change the message even a week later. This is a moving target. This is a new virus. And I know in public health and in medicine, we tend to be very careful. But during a pandemic, we can't afford that. The risk is to go in immediately and say what we see. But educate the public and tell them we are looking at data coming to us. If the data changes, the recommendation will change. And then don't hold ourselves to, well, when we said you do this, we have to stick to it and keep doing what we did. That doesn't work. And here in the United States, if you live in the East Coast in Florida and you have a hurricane coming, I mean, if they change the direction of the hurricane, nobody questioned that. Based on your data, you change your projection. We didn't do a good job educating the public that, we may have to change these messages based on the new data that's coming to us. But we have, when we make a change in a recommendation or in a policy, we have to make it clear what data did we base that on. And here is the data and releases. So CDC made some mistakes around that, not releasing the data immediately behind what they are making. And sometimes they delayed making a decision even when the data was telling them they should do that. Politics and science. And we need to be very careful as scientists to stay out of politics and also to keep politicians away from science. I know it's easier said than done, but we can't afford as scientists to be viewed as in politics. Yeah, I have political views, but you only see my political views when I go and vote. You don't see who I'm voting for. But the only time I practice this politics is when I vote, not when I'm presenting, not when I'm talking. And we need to protect scientists. Many scientists, including myself, I got threats at home. I mean, I got mailed letters at home, email, etc., calls. So we need to protect scientists, and we need to protect science, and we need to create a system that scientists can speak freely, irrespective of politics, and they should be not punished for what they do. Global assistance. We need to help each other. Before I move to global assistance, politics and science is very important also if you look at climate change right now. And we need to make sure that that debate also is not political. So global assistance, we need to help each other. And, many countries right now lack the expertise for surveillance. And here where CDC has done a good job through something called the Field Epi Training Program, where they have trained epidemiologists in many countries. And throughout this pandemic, we could see here at IHME, in certain countries where there was a field epi training program, there was, more easier to convert to doing surveillance and producing some data. So we could do better in training people to do surveillance, training people to do lab, training people to do many of the things that we are privileged here to do in the United States, but also assistance when it comes to medication, vaccines, donation, because we're not safe until everybody else is safe in the world. And a new variant could come from anywhere else, and we need to protect everybody in the world in order to protect ourselves. The other lesson that is very, we at IHME, because we do this globally, and I told you we have over 7,700 collaborators, we take lessons from other countries and we apply it here. The US doesn't do that. This was a big mistake during COVID-19. The US is busy in what's happening in the US. So I'll give you a very specific example. When Delta was started to spread in India, we saw it here at IHME because we've seen a rise in Delhi in cases. And we knew from zero prevalence survey, Delhi at that time was like about 75% protection from infection. They had a big wave before. But still, we've seen an increase in cases. So we knew automatically that's an immune escape variant that's spreading in India in many places. We've seen it coming. We here put a warning in our briefs saying, there is a variant that's circulating in India. We need to be very careful. At the same time, CDC was saying, drop your mask, don't wear a mask, if you remember in May. This was a bad mistake. I mean, we don't live by ourselves here in the United States. We need to learn from other countries, and we need to accept the science in other countries. Of course, we criticize it, we look at it, we review it, but it's very important for us to look around us, what's happening everywhere, and not to focus internally and only internally about our own situation. I'd like to end by future health threats. Have we learned, Mike, it's a question. Have we learned to be ready for the next health threat? I'm not talking about another pandemic or another virus. but other things such climate change. Climate change, you know, if we tomorrow as a humanity, every country in the world, decide to do exactly by the book what's right to protect our climate and our environment and our planet, we project at IHME that temperature will keep going up for 50 years. Let me repeat that. Even if we do everything tomorrow by the book, temperature will keep going up for 50 years. Instead of going up that's very sharp high, it will go slower up, but it will take 50 years to start declining because climate change today is impacted by what we did 10, 20, 30 years ago. Have we learned our lessons to work together, to protect ourselves, to make sure that we have enough food to feed everybody? WHO or the UN is about to announce, coming soon, that the planet has now 8 billion people. Have we learned to work together to protect ourselves? What crops to grow? What the impact of migration? What the impact on diseases? What's the impact on new outbreaks and new pandemics? I hope we did. And I hope we didn't lose our humanity. Unfortunately, during the COVID-19 pandemic, there was some really not encouraging news where some rich countries, bought more vaccine than what they needed, fair in a way, because they developed the vaccine, including here in the United States, but they were very slow of donating the vaccine and helping others. I hope we learned our lessons, and I hope we can come together in order to protect ourselves, our future generation. Thank you very much. I'll stop here and I'll take any questions.
Thank you, Dr. Mokdad, for that informative presentation. And we will now start the live Q&A portion of this webinar. If you have any questions you want to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. So let's get started. It looks like we already have some questions coming in. Dr. Mokdad, our first question, what are we doing today to avoid what happened in 2020, 2021?
Quite honestly, I mean, I hate to say that, not much. For many countries at this time and age, due to inflation and the economy right now, it's very hard for me, even as a, population health professional. I was born and raised in Lebanon. It's very hard for me to call the Minister of Health in Lebanon and say, be prepared for the next wave, where he is now. He's dealing with an emergency, cholera is increasing, a lot of problems. So many countries, unfortunately, right now are in a worse situation in order to prepare for the next pandemic. So, and it's part of it is the pandemic itself, and part of it is the inflation. The short answer is unfortunately not. I hope the world will come together, the UN or others, and have a plan and support the countries who can afford to support other countries in order to come with a plan to be ready for the next global health threat. I wouldn't call it pandemic.
Thank you so much. Now, this next question, the pandemic has set us back and there's a long road for recovery. Any insight on that recovery based on your expertise that you could provide us?
Very good question. So, when I was at CDC, full disclosure, I worked 20 years at CDC, and most of what I learned from great people who are dedicated health professionals at the Centers for Disease Control and Prevention. And I'm proud that I have served 20 years at CDC. So I did a lot of emergency and refugee health. And then for emergency, you do preparedness, you do response, and you do recovery. And preparedness, unfortunately, now we talked, it wasn't very good throughout COVID-19, and preparedness doesn't look good in the future. So it will impact, of course, the response. But recovery is something else. My concern right now is during this pandemic, many people lost their job, lost their income. So we don't know what did they do? Did they spend less? Did they cut down on medication? Did they cut down on saving? Did they borrow money? That impacts your social demographic, social determinants of health. Many people delayed their education. Where I come from in the Middle East, I'm so concerned that a young woman who hasn't been to school or to a university 2 years or 3 years will never go back. And then what are we doing as a humanity in terms of monitoring, surveillance, and surveys about recovery? What countries need to do? how fast could we go back to what we were projected to do from what IHME was doing? This pandemic set us back, and we haven't uncovered the long-term effect. I'm not talking about long COVID, which we know is a problem, and we published on that. But even to go back to normal, people delayed their medical care, delayed their education, less income. We're in for a difficult time coming forward unless we come together and we look at it and we help countries, and each country will understand what they need to do in terms of their own recovery. We're not going to be able to move forward as fast as we should.
Thank you so much, Dr. Mokdad. And with all that you've shared right now, our final question, are we ready for another pandemic?
Unfortunately, we're not. I mean, I hate to be, I'm optimistic by nature. I'm always optimistic. I mean, I grew up in a civil war in Lebanon, and look where I am. I'm always very optimistic. But unfortunately, we're not, for many reasons. We haven't learned to work together. We haven't learned that what happens in a remote area in a country will impact me here in Seattle, or whatever happened in the US will impact me here in Seattle. And we need to do a better job for preparedness. And I haven't seen it, unfortunately. It was every country, protecting itself. There was no common purpose, no common objective globally. And WHO tried as best as it can, but we didn't see it. And I hope we do a better job for preparedness. But again, because of the inflation and the situation right now, many countries, and I don't blame them, cannot put the resources into preparedness because they're dealing with the immediate. In public health, you have immediate and important. Sick person today, you have to treat them, and you have to prevent, which is important, to do prevention to prevent illness in the long term. In general, what is important should not be at the expense of the immediate. You need to invest in both, but many countries can't afford to do this luxury right now. Invest in treatment, invest in dealing with the situation and recovery, and also investing in preparedness. Important.
Very important. Dr. Mokdad, thank you very much for your time today. Would you like to provide any final comments for our audience before we go?
Yes, thank you. I mean, again, thank you everybody for attending. Thank you, Lab Roots, for inviting me. It's always a pleasure to join you and discuss COVID-19. My final remark is a call for action for all of us. Many of us know of people who suffered from COVID, lost loved ones, lost businesses. I urge each one of you to help when you can. Many people cannot afford to eat. Many people cannot afford to keep electricity in their homes. So let's do each one of us do his part, her part, in order to help ourselves. It takes a village, and this country succeeded, and look where we are right now because we historically worked together as a village. Let's go back to that and look at our neighbors and make sure we help each other. Thank you very much.
And thank you again, Dr. Mokdad, for your time and for your important research. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period will be addressed via the speaker, your contact information that you provided at the time of registration. This webcast can be viewed on demand for 2 years until October 19th, 2024, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until then, take care, everyone, and bye-bye.